Good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Our episode today is on pruritus, focusing on a potpourri of different topics, including mechanisms and myths and management across a variety of different chronic diseases. We have a fabulous trio of guests with us today who are the authors of a recent publication that's titled Managing Pruritus in Advanced Chronic Disease in the Journal of Palliative Medicine. First, we have Dr. Ebru Kaya. She is an associate professor of medicine and division director at the University of Toronto in the Division of Palliative Medicine and the site lead for the Toronto General Hospital Palliative Care team. She's made important contributions to palliative care at the national level through her work with the Canadian Society for Palliative Medicine, where she has served as treasurer and president and program director for the subspecialty residency program in palliative medicine in Toronto. She's the co-lead for the first national quality standards for palliative care in Canada, and when she's not working, one of her favorite things is to try out different cuisines from around the world with her husband and two sons. Welcome, Ebru. Second, we have Dr. Gordon MacDonald. He is a palliative care physician working in Fredericton, New Brunswick. He has academic appointments through Dalhousie University and Memorial University in Newfoundland. Gord has served in multiple roles through the Canadian Society of Palliative Medicine and has great interest in rural access to palliative care. Gord is a proud husband and father of two boys and lifelong resident of New Brunswick. And in March, he adopted a Dachshund puppy that was born with one abnormal front leg and named her Pi based on the 3.14 functioning limbs. Welcome, Gord. And third is Dr. Romaine Gallagher. She is a clinical professor in the Division of Palliative Care at the University of British Columbia. She was the founding director of the Division of Palliative Care at UBC. Before retiring from clinical practice, she was a family physician for over 12 years and a consultant palliative care physician for more than 25. She's held multiple administrative positions at Providence Healthcare in Vancouver and continues to be involved in the Canadian Society of Palliative Medicine. Romaine is married and has two children and three grandchildren who've kept her sane, along with rock hounding and gardening. So welcome, Romaine. Our format today is going to be a presentation, and I will hand the mic over to you three wonderful folks.
Thank you so much for having us. It's a pleasure, it's a privilege, and thank you for joining us on the 4th of July, which is such a meaningful, important holiday for you in the U.S. Starting out, we have no great disclosures to offer. We are truly presenting from coast to coast in Canada. Romaine is presenting from Vancouver, which we would like to just take a quick moment to acknowledge that the lands we're joining from, that we recognize as Canada, represents unceded, unsurrendered territory of Indigenous peoples, including the Tsleil-Waututh, the Squamish, and the Musqueam from Vancouver, the Mississauga, Chippewa, the Haudenosaunee, the Anishinaabeg, and the Wendat in the Toronto area, the Wolastoqey, the Mi'kmaq, and the Passamaquoddy peoples in New Brunswick. The treaties signed did not deal with the surrender of land, rather was a foundation for ongoing relationships between nations. We just pay respect to the elders, the knowledge keepers past and present, and we strive to develop an understanding and closer relationships with Indigenous peoples from coast to coast. I stole most images from Google, so full credit to them. I've tried to reference them as best possible, and we were looking at it from a point of view of what questions were we hoping to address. And so, what do we understand about itch? How can we classify? Are there myths and missteps in our approach? What does it do in terms of quality of life for people suffering with chronic, significant advanced illness? Are there takeaway points based on specific systems involved, such as end-stage renal disease, chronic liver disease, congestive heart failure? So with that, Romaine, I will hand it over to you for the next portion.
Great. Next slide, please. So where to start? I just couldn't resist saying, well, from scratch, of course. Chronic pruritus only exists if it's longer than 6 weeks. It can be local or diffuse. Interestingly, we've had the same definition of itch since 1630, when it was defined as an unpleasant sensation that results in the urge to scratch. And I think that is pretty amazing. And I think it really says a lot about how little we've been learning about this and how long it's taken us. Itch can range from a momentary sort of sensation to an unrelenting preoccupation. And I have seen people like that, and it's just horrible. It's really, it affects sleep, mood, quality of life, and it makes other symptoms worse, which I remind people is very similar to pain, because pain also makes other symptoms worse because of that. It actually took us to the mid-20th century before we could understand that it was a sensory neurosis that may or may not have any symptoms without lesions, etc. So let's go into the it's very, very common, 70%, 40%, 65% in our major organ failure diseases, and also very much present in diabetes because diabetes encompasses a number of these chronic organ failure diseases. So the 4 major causes of itch, dermatologic is localized, mediated mostly by histaminic C fibers. They're the ones that take the sensations through to the dorsal root ganglion and up to the brain. Now, interestingly, people sort of thought, okay, histaminic, we know what to do with that. We'll give everybody an antihistamine. And it's maybe been the job of palliative care people to often remind our specialist colleagues that that doesn't work very well, actually, in the other disorders, the other itch disorders. Well, why not? And partly because the messages are taken from the surface by non-histaminic fibers, and that's taken us a long time to work that out. So there are other, Gord, can you go back? We've got auto something on. Okay. There are 3 other causes, and I'm not going to get into, they all interact with each other, because as you know, if you scratch and you actually cause lesions or damage to the somatosensory tissue, you end up with a neuropathic type issue too as well, where you've actually got, like pain, you've got a disease of the somatosensory system. And so this is the way one has to keep in mind that itch kind of mirrors pain in that way. And these other 3 can be, or other 2 can be overlapping. Psychogenic is really where itch is triggered by psychological factors. So next, please, Gord. Systemic. We've done the histamine business. We talked about that. Neuropathic obviously gets triggered and so on by substances as neurotransmitters. Histamine is listed in there, but that's extremely rare. Carry on, please, Gord. And psychogenic has things to do with the dopamine system and that. I'm not going to go through this in detail, just to point out that our really huge contribution in the last 20 years has been discovering all these causes of itch and triggers of itch called pruritogens. That's really helped us because these will become drug targets for specific kinds of itches over time. Hopefully, that's the plan. In systemic disease, there's a lot of contributors, as well as skin changes from the disease. The disease itself can cause itch. The treatment of the disease can make it worse. Medications can trigger it. And there are many pruritogens, as we have some here. The other thing that you always need to keep in mind is that it is also possible to have a skin disease as well as a systemic condition. So thank you, Gord. Over to you.
Thank you. And sorry about bouncing around on the slides there. So when we look at some of the effects and the outcomes of pruritus on the person, as you alluded to, Romain, sleep disturbance, which can certainly overlap with so many of the other elements of quality of life. If sleep is disturbed, then pain, nausea, energy, interest, concentration, all of those can be impaired. Um, it it certainly can lead to social withdrawal, avoidance, to changes in terms of relationships among our close friends as well. If you are in a social situation and scratching all of the time, it certainly is an uncomfortable sensation to be in the room with people observing. Um, so it really can spill over into every other aspect of quality of life. So with that in mind, why is it that we don't necessarily address it? And so why might it be missed? And so with many chronic diseases and such a great degree of symptom burden, we're often focused on other things. So the energy level, the pain, the nausea, the things that people traditionally really associate with their degree of suffering, that itch feels like background noise. And if it's not part of our instinct to ask for it, we can easily overlook. Along the same lines, do the patients offer that it's so distressing to them? It's I can't tell you how many times I think we've all had the same experience as someone saying, I thought things would be worse. I thought I would feel worse. This is almost background noise. I'm not suffering from terrible pain, so something like itch feels like such a small thing to mention. I almost hate to bother you by bringing it up. But in looking at the effect on quality of life, it certainly can be terribly distressing. So are the other symptoms prioritized instead? And how have we done in terms of offering effective treatments? Um, so as you say, Romain, we often we hear of many people, and I've been guilty of it myself, throwing antihistamines into the mix when that's been the smallest part of the process for mediating itch. So being sure that we have the right tools to offer at the right time. And then how discouraging is it when the treatments that we offer don't offer tremendous benefit? So I mentioned it, we tried something, it didn't work. The end, I'll move on. So in terms of thinking about it from an assessment point of view, this is the Edmonton Symptom Assessment System, and it's revised for renal purposes, which does include itch as one of the symptoms within the complex of chronic kidney disease. So it does offer that prompt to really open the door to allow people to discuss it. Moving forward from there, the the 5D itch tool, which the reference is on the last page for both of these, but it really explores in greater detail how long, how bad, how much of the body is involved. Does it seem like things are getting better or worse? what's its effect in terms of your day-to-day? And so it really does include some of the functional end of things as well. Is it impairing you for your recreational activities, your household, your work, your school? How is it influencing every element of your day to day? For specifics about investigations and so on, that would be much more tailored based on the underlying disorder you're considering. So targeting based on the underlying systemic illness. And so with that, I will turn it over to Ebru.
Thank you. Thanks, Gord. Before we go into more detail for the three diseases in a bit more detail, just remember that there might be more than one cause of pruritus in a patient, including cancer as well as older age. So look for other contributors and comorbidities. And where possible, seek to treat the underlying condition, though this may not be as straightforward in heart failure, and we'll find out a little bit later. So next slide, please, Cord. So as we found out, pruritus is common in patients with chronic kidney disease. Not all of them have severe symptoms, but a significant number don't report it because they don't think to link it with their kidney disease. So it's really, really important, as Gord says, to aggressively look out for it and assess it. And in terms of other causes of pruritus, for example, when you're assessing your patient, urticaria may indicate an allergic component. We don't fully understand all the underlying mechanisms in renal failure, but we think that there are skin changes that take place similar to what happens in older age, leading to a loss of sebaceous glands, which leads to a change in the skin pH, and then dryness and ultimately itch, as well as an imbalance of the endogenous opioids, as well as neuropathy. And I'm going through some of these, but it's just to remember, similar to how we would approach a patient with nausea and vomiting, just remember to have a really thoughtful, methodical approach. And for patients on dialysis, there's lots of studies that show that optimizing dialysis can really help improve itch. So just being mindful of that and making sure that we collaborate with our nephrology teams. So moisturizers and emollients have been shown to improve uremic pruritus and should always be used first line when considering drugs. If we need to add in other medications, remember to start low doses, titrating gradually, especially drugs that are cleared renally, such as gabapentin and pregabalin, which have been shown to improve itch in randomized control trials. Next, consider selective serotonin reuptake inhibitors, both of which act on the central inhibitory pathways. And again, remembering those imbalance of the endogenous opioid pathways. The mu opioid receptor activation promotes itch, whereas kappa opioid receptor agonists inhibit itch. So kappa opioid receptor agonists, such as nalfurafin, have been shown to help, but their availability and insurance coverage remains a barrier for its use in North America. So if kappa opioid receptor agonists aren't an option, naltrexone, which is a non-selective opioid agonist, can be considered, but unfortunately it hasn't been shown to be effective in randomized control trials in renal failure. There are other agents that have been tried. I'm not going to go through them in detail, but one to note is UBV therapy, which is widely used for atopic dermatitis and psoriatic pruritus. It's been shown in many studies to help with uremic pruritus as well. Okay. Next slide, please, Gord. So in chronic liver disease, our approach should definitely include trying to see if we can treat the underlying liver disease. And cholestasis and increased bile acids are definitely linked to itch. Therefore, bile acid sequestrants such as cholestyramine and ursodeoxycholic acid, which increases hepatic clearance of bile acids, are supported by many studies. But there are obviously other mechanisms similar to chronic kidney disease, such as the imbalance of the endogenous opioid system, elevated neuropeptides, which may explain why elevated bile acids aren't always correlated with itch or its severity. And similar to before, emollients should be first line, followed by rifampicin, which is thought to increase the excretion of the prurigenic compounds. It has been shown to improve itch in many studies, but not all. Naltrexone has more studies supporting its use in chronic liver disease compared to chronic kidney disease. And if nalfurafin is available, then it definitely should be used. And again, SSRIs, SNRIs should be tried, but there aren't any randomized control studies in liver patients. And unfortunately, unlike in chronic kidney disease, randomized controls unfortunately do not support gabapentin use in itch and chronic liver disease. Okay, next slide, please, Cord. Unfortunately, we have less studies in heart failure, and we really don't know much about it. But the one thing that we do know is that many of the medications that we use for managing heart failure are unfortunately pruritigenic themselves. So ACE inhibitors, beta blockers that we commonly use have been shown to cause itch. But similar to all the other disorders, remember it's important to assess for other comorbidities and look and assess the skin as well. And in some cases, renal impairment, liver dysfunction may be the contributor of itch in heart failure. And regarding medications, if we can't discontinue the drugs that we think might be contributing to itch, then loop diuretics are thought to do the opposite, where they're thought to activate the inhibitory itch pathways and are definitely worth considering. Gabapentin, pregabalin are worth trying, as well as mirtazapine, though we don't really have studies guiding the use, unlike in chronic kidney disease and to a lesser extent chronic liver disease. Next slide, please, Cord. We're almost there. Really wanted to make sure that you guys have some references, including our study. And the reason for that is we created what we are hoping will be a really helpful table. If you don't mind showing, please, Cord, that we're hoping can be helpful practically just to be able to guide people, as well as another table. And again, I'm cognizant of the time. Again, if you are a person who prefers a list of drugs and the kind of things that it's useful and the mechanisms, whereas our other table is more around the disease and then the drugs to use for that disease. So thank you very much for listening to us.
Thank you, guys. I've got an observation and a follow-up question. I am struck by how similar the mechanism mirrors pain, and particularly chronic pain, right? You've got those sensory feelings that may or may not actually have any damage anymore. And you think of chronic pain as, that central sensitization and problems with inhibitory spinal cord control. And it's remarkable how so many of the treatments are similar to what we use for chronic pain, right? The gabapentinoids, the SNRIs, tremendous overlap. A lot of my patients are on some combination of opioids and gabapentinoids, just by the nature of many of the consults I work on. I wonder, I doubt there's any evidence for this, but I wonder if it's preventative in some way. All my patients are already bathed in a gabapentinoid. Maybe it is preventing pruritus in some way or lessening it in some way. And maybe that's part of also why I'm not seeing it, in addition to me probably needing to be better to ask. But thoughts?
Well, yes, there is a very good article written in 2023 that is in our paper talking about the neural networks. And they've shown that central sensitization does occur in itch. So itch can spread. It can become more aggressive, more all-consuming, just like pain can. So yeah, maybe you are preventing things, but definitely I think we have shown that the two of them are cousins, if not siblings.
In my experience, Marty, some patients might be on, those amazing drugs that have been shown to help in itch, but many of the patients that I see are referred by specialists who don't really have a lot of this knowledge. And so patients come on antihistamines and they're sedating antihistamines, which is fine, as in when the patient's asleep, they don't experience itch. That's great, but they can't then use those medications during the daytime. And that's when we end up with the problems that we do.
Yeah, that's my impression of the literature for antihistamines as well, is that they may be effective, but it might be effective because they're sedating rather than
That's exactly
actually hitting the right target.
And and that was sort of a launching point for this article, for this topic, was that hydroxyzine was not going to be available for a window of time, and it was
Hmm.
there was a request based on it's something that has been so widely used for pruritus, and again, it's you could make an argument in chronic disease that if it had never existed, it may not have influenced how our approach to itch
Hmm.
actually developed. So.
Oh, tremendous. All right. Well, I really appreciate you guys joining us today. This was a lovely presentation, hitting all these beautiful points, and I will pass your PowerPoint on to those that typically tune in.
Thank you for having us.
Yeah, thank
Absolutely.
you. Yes, and happy anniversary day to all of our friends in the United States.
Absolutely. All right, guys. Have a wonderful weekend. Toodles.